there's a fellowship thing at UNC that was named after Holden Thorpe. But you know, he was the president. He was the chancellor there before coming back to WashU, and so then, anyways, it's like a community engaged faculty kind of deal.
Hey, Myra, there's a question about a certificate that I think that's a question you and your group would need to answer.
Okay.
So can folks hear us now or not? Not.
They can hear us.
Okay. So stop saying embarrassing things, Brenna. We should keep it appropriate.
Right. No secrets.
All right.
Looks like there's 19 on right now.
And how many people registered? I was blown away by the number that was cited, but I don't know if that's real or not. Brenna, they're all coming out for you. There's whatever number I saw was huge.
I don't remember a number, but I probably just missed it.
I know I've been part of some presentations recently where the registration number is significantly higher than the number attending, but I think if people are getting the recording, I've done that as well. Sign up for something even when I know I'm not going to be able to attend live, so I can watch the recording. I'm guilty of that.
I don't have the answer for the certificate, but I will email the person and try to get an answer. I'm sure I'll get it while the open classroom is happening, and then I'll have an answer and I'll put it in the chat, or I'll chat it to maybe Brianna or Byron.
Great. Thank you, Myra.
Leo's here.
Hey, Leo. For those of you who are joining, we're gonna give it a few minutes. We'll probably start in earnest at about 12:31, 12:32. But welcome. For those of you asking about a certificate, if it seems like this question is popping up again, we're going to get back to you on that. I'm not aware of CEU or certificates being offered for these, but Myra's going to check and we'll get back to you on that point. Thank you, Kelly. Welcome everyone who has joined already or who's just coming online. I'm just going to give it maybe one more minute, and then I'll start with some housekeeping things and then introduce our speaker. But welcome, thanks so much for joining today. Just give it a second here. Okay, I'm sure folks are still joining us, but I think we should kick off here. Welcome everyone to the Brown School's Open Classroom Seminar, which is co-sponsored today by the Center for Mental Health Services Research. My name is Byron Powell. I'm a faculty member at the Brown School and co-director of the Center for Mental Health Services Research with Dr. Leo Cabasa. And it's my pleasure today to be here with you. Thank you again for joining. Just a few reminders as we begin. This is obviously being offered on Zoom as well as Facebook. So I believe YouTube Live. So some folks are joining that way as well. Just a reminder for those who are on Zoom that this is in the webinar format. So we cannot see or hear the audience or call on any raised hands. But the chat is enabled, and we encourage you to make this an interactive experience. Introduce yourself, ask questions, or make comments in the chat. Please post any questions at any time, but the Q&A session will be held for the last 10 to 15 minutes of the session. For those of you who are joining us via YouTube, we are not able to moderate any comments or chat through that. So we apologize, but feel free to engage afterwards. We also encourage you to attend several upcoming events. So on May 5th, we have an advocacy and allyship with Asian American and Pacific Islander communities, a conversation with organizers and advocates. That's through the Brown School Open Classroom. On May 12th, we have a session on robotics, artificial intelligence, and ethics. Both of those seminars will take place at 12:30 Central Time through the Brown School Open Classroom. I also want to mention our last Center for Mental Health Services Research Seminar of the year will be delivered by Dr. Michael Park and is titled Determinants of Mental Health and Stigma to Mental Health Service Use Among Filipino and Korean Americans. And I'll put that in the chat towards the end of the seminar. Now it's my pleasure to introduce Dr. Brenna Maddox. Dr. Maddox is an assistant professor at the University of North Carolina at Chapel Hill in the Department of Psychiatry. She is an implementation scientist for the UNC Teach Autism program, and her work focuses on improving community services for people on the autism spectrum across the lifespan. She's particularly interested in engaging autistic individuals and other stakeholders in community partnered research, preventing suicide and self-harm in people on the autism spectrum, and training and supporting community mental health clinicians to work with this population. Her research has been supported by the National Institute of Mental Health, the Patient-Centered Outcomes Research Institute, or PCORI, the Organization for Autism Research, the Foundation for Hope, and the FAR Fund. Dr. Maddox is also a clinical psychologist, a deputy editor for the journal Autism in Adulthood, and co-chair of the American Association of Suicidality's Autism and Suicide Committee. So please join me in welcoming Dr. Maddox, and we really look forward to your talk as well as the discussion afterward. Thank you so much for joining us.
Thank you so much for having me, and thank you everyone for joining today. Appreciate your interest in this topic. It's a topic very near and dear to my heart, so I'm excited to have this opportunity to talk with you all today. And like Dr. Powell said, I'm really looking forward to the discussion. Please feel free to put comments into the chat as we go, and I'll make sure to save some time for discussion and Q&A at the end. So just a brief overview of what I am planning on covering today. I'm here to talk about suicide risk in people on the spectrum, as well as what we can do when we're working with or supporting someone on the spectrum who's in crisis. Most of my work in this area has been community partnered, and I've learned so much from my stakeholder partners, so I'd like to share a little bit more about that. And as Dr. Powell mentioned, I recently was awarded funding for a suicide prevention study funded by PCORI, which is a stakeholder engaged project. So I'll share a little bit about that before moving to questions and discussions. A quick note about the language that I'll be using in today's presentation. I'm not sure about everyone else here, but I know for me, when I was in graduate school, I was trained to use person-first language when referring to individuals on the spectrum. So person with autism or people with autism. More recently, we've been learning from autistic individuals directly that many prefer identity first language or autistic person. And my autistic partners have expressed this preference for identity first language. So you'll be hearing me use identity first language in today's presentation. If anyone is interested in learning more about some of the history around this language, as well as other language used in autism research, I like to give a shout out to this paper that was published a couple of years ago in Autism and Adulthood, talking about ableism and ableist language. It says suggestions for autism researchers, but I think it's more far-reaching than that group only. All right, so I am not sure of everyone's backgrounds here in the audience today. I was hoping we could use the chat function actually in Zoom. If you could just chat in, what does autism mean to you, or what do you think of when you think of autism? I'd love to see some people's responses for that. So what do you think of when you think of autism? See a new way of thinking? Highly variable phenotype. So yes, a lot of diversity and that spectrum nature. Great, thank you for all these responses coming in. Very unique to each individual, divergent thought patterns, unique and capable individuals, needing help with social skills, so different for each. So I think a lot of people are picking up on the variability. A person with alternative development, there isn't one answer, absolutely. Really, it is really difficult to capture in just a few words, absolutely. It looks like we have some family members of individuals on the spectrum here and some self-advocates, which I'm really excited about. Welcome, everyone. I love this quote, if you know one person with autism, you know one person with autism. That quotation is often attributed to Dr. Stephen Shore, a self-advocate. You're going to hear me talk a little bit more about Stephen in a few minutes. Great. I love hearing about different backgrounds and perspectives that people are bringing today. So thank you all for sharing that. And what is very refreshing is sometimes when I talk to individuals in the community who are thinking about autism, oftentimes there is this view that, oh, autism is typically a white boy, right? Like pictured here on the screen. And we're really trying with a lot of our work to expand everyone's perspective to understand truly that variability that so many people were putting into the chat, and also to learn more about autism directly from autistic individuals. So I really like this information on this slide here, autism as explained by neurodivergent individuals. So when asked what are some of the main features that they experience on the autism spectrum, people said difficulty filtering input and stimuli. One person said, my autistic mind is a computer, super specialized in collecting detailed information and realizing the relationship between the details. And then someone said, some people say that autistic people don't feel enough. We're saying the exact opposite. They feel too much. All right, so I know I'm not here to give an autism 101 presentation. I'm sorry, someone said they're not seeing the slides. Are other people having that problem? Let's see. Okay, great. I'm betting someone can give some tech support to Paige. I think it was Paige in the chat who's not seeing any of the slides. Thanks for letting us know, Paige. We'll make sure that gets fixed for you. All right, so I'm not here just to talk about autism broadly. Today, I really want to focus in now on suicide and autism. What do we know? And I'll give the disclaimer that for a long time, suicidal thoughts and behaviors in autism have been under-researched. However, it is a quickly growing area of study. And at this point, the majority of published studies have focused on prevalence estimates and risk factors. So that's what I will briefly cover now, along with some emerging research on warning signs. So what we know about prevalence is very concerning. I do want to preface this by saying I know this is a heavy topic, talking about suicide and premature death. And of course, if anyone is finding this information triggering and needs to take a break, please take care of yourself. As I mentioned, what we know about the prevalence of suicidal thoughts and behaviors in autistic individuals is quite concerning. There's now convincing evidence that suicide is a leading cause of early death in the autistic community. And the prevalence of suicidal thoughts and behaviors are significantly elevated in autistic children, adolescents, and adults compared to the general population. So clearly this is an area we need to be focusing on more. I'm not going to spend too long on the prevalence estimates on these numbers. I just wanted to highlight that there is quite a wide range reported in the literature. You can see here for children and adolescents, we see ranges from around 11% all the way up to 72% for suicidal thoughts or suicidal ideation. Another wide range here for suicidal behavior. A lot of this variability can be explained by differences in how suicidal thoughts and suicidal behaviors were measured, right? So was it self-report? Was it looking in the medical records? Was it from a parent's report? And also variability in the samples. Was this from a clinic that was seeking mental health services? Was it from a school-based setting or a community setting? One important point I'd like to make here is that suicidal thoughts and behaviors have been reported in young kids under 10 years old. And so I think no matter what age group you're working with or supporting, if there are direct professionals listening, this is an area to have on your mind. When we look at the literature on autistic adults, we see similar wide ranges here reported for suicidal thoughts and suicidal behaviors. Again, mostly explained by differences in the sample or the measures used. So just to give you a concrete example of that, this 19.7% came from a study on supported employment. So these were all autistic adults who were employed and who were getting supports in their employment settings. The 66% came from a clinic in the UK that specializes in first-time autism diagnoses for adults. So these were adults who did not have a diagnosis of autism throughout their childhood and adolescence and were receiving a first-time diagnosis in adulthood. And we'll talk some more about how that late diagnosis and unmet support needs can often be contributing to suicidal thoughts and behaviors. So knowing the elevated prevalence estimates, I think a natural next question is why? What makes autistic individuals more likely to consider, attempt, or die by suicide? So when we take kind of a first glance at this, kind of on the surface level, we know that there is a lot more research out there on suicide risk in the general population, so not specific to autistic people. And the factors known to increase the risk of suicide in the general population, those factors themselves are more common in autistic individuals. So for example, social isolation, abuse, low mood, these types of things are known to increase the risk of suicide in the general population, and they're more common in autistic individuals. So again, at first glance, we could say, oh, well, that explains the increased risk. However, in studies that have compared autistic individuals to non-autistic individuals with comparable rates of these factors, the autistic individuals still have increased rates of suicidal thoughts and behaviors. So that, of course, would make us need to consider additional factors, some that may be more specific to autistic individuals. So I'm going to share with you just briefly, for the sake of time, a list of risk factors here. This is not an exhaustive list, but these are some of either the most studied and supported risk factors for suicidal thoughts and behaviors in autistic people, and also some that are newer in the research, but maybe more specific to autism. So the first, I'm sure, is not surprising to people here. Co-occurring psychiatric conditions is a risk factor for suicidal thoughts and behaviors in autistic people. And there have been a few national studies recently that really drive this point home. So I'll give you one example from a large Denmark study, this one down here, that recently came out, they found that of the group of autistic adults who had either attempted or died by suicide, more than 90% of them had a co-occurring psychiatric condition, with anxiety and affective disorders or depression being most common. So that number definitely caught my eye, more than 90%. A lack of social support, and then more generally unmet support needs. This has also been consistently shown to be a risk factor for autistic individuals. Something called camouflaging or masking, which some people, this may be a newer term for you. In the autism field, we're learning a lot about camouflaging or masking, which basically is where autistic individuals attempt to camouflage or mask their autistic traits in order to try and fit in to social situations. And we're learning more and more that camouflaging may negatively affect the mental health of autistic individuals. A late diagnosis of autism has also been shown to be a risk factor. I think this again relates back to some of these unmet support needs, right? If you don't have an accurate diagnosis, you're going to miss out on some opportunities to be linked to autism specific or tailored resources and supports. Females on the spectrum are at a particularly increased risk of suicidality. This paper that came out a couple years ago, this adjective really caught my eye: unrelenting, depression and suicidality. And they had some quotations from women on the spectrum or women with high autistic traits, really talking about this experience, that it feels like it's not a fleeting or temporary experience, but that it's unrelenting. And then the last one that I wanted to mention today is something called autistic burnout. And this again is a somewhat newer term in the field, definitely not a new experience for autistic people by any means, but as researchers, I think we're finally catching on and starting to learn some more about this. If you're interested in learning more about autistic burnout, this was the paper that came out a couple of years ago in the journal Autism in Adulthood that really describes, both defines and describes autistic burnout. So I won't go into a long explanation right now. Really, the way to think about this is a mismatch between an individual's abilities and the supports that they are receiving in their environment. And so the demands of the environment are really exceeding kind of their capacity. And they feel burned out. There's this cumulative load and can often result in a loss of functioning, kind of a regression of skills, as well as emotion dysregulation and decreased tolerance to sensory stimuli. And autistic burnout has been linked to increased thoughts of suicide. All right, so that was my brief overview of some of the literature around risk factors of suicide in autistic individuals. Risk factors are really those characteristics or those conditions that make it more likely that someone will think about, attempt, or die by suicide. We also want to think about warning signs. So warning signs indicate a more immediate risk of suicide. So if I'm a clinician in the room with someone, I'm really looking out for those warning signs in the moment to know if I need to intervene, if I need to refer them to a higher level of care, those kind of things. Unfortunately, there's even less research in the autism field on warning signs compared to risk factors. However, one thing that we are learning more and more about is that the warning signs may look different for many autistic people. So even how autistic individuals show distress, convey that distress on the outside, can look very different than neurotypical distress and crisis. And we'll talk some more about that in just a moment. So I wanted to highlight a few different free publicly available resources in this presentation. And I also want to highlight one of my closest collaborators and friends, Lisa Morgan. Lisa is really the brilliant mind behind these resources. She's also taught me a lot about how to get things out quickly into people's hands through these online toolkits. Me coming more from academia with the journal articles, which also have a time and place, but I've learned a lot from Lisa about these toolkits. So Lisa is the founder of the Autism and Suicide Committee of the American Association of Suicidology. She's a self-advocate with lived experience around suicidality, and she's also a suicide loss survivor. So I definitely would encourage you, if you're interested in learning more about Lisa's work, her website's here at the bottom of the screen. And then I'll share a website near the end of the presentation that has all of these toolkits together on one site. So this toolkit is about the warning signs. It really goes through each of the suicide warning signs for the general public and provides some considerations to pay attention to when talking or working with an autistic person. I'm not going to go through all the considerations today. It really goes through each of the warning signs and lays out some thoughts and some examples of things you may want to ask as a follow-up question. But I do want to share a few general considerations. The first is that the thinking process of autistic people is often very literal. And so when attempting to assess for warning signs, we need to consider the exact meaning of what we were saying or what we're trying to find out. Because autistic people will frequently answer what they're asked in a literal way. They may give a response, but not the information that we might be looking for to help them. So again, Lisa has really helped me understand this is truly a two-way street, right? Where the autistic person be interpreting what we say very literally, but also they may be giving us literal responses. So we also need to have a literal ear when we're listening for what they're saying. So let me give you a concrete example of this as well. Oftentimes as a clinician, I may ask a kind of a screening question for suicide risk, something like, do you want to hurt yourself? Okay, so if I asked an autistic person, do you want to hurt yourself? They may answer no, because they don't want to. They heard me say, do you want to hurt yourself? They answer no, but if I had asked, do you have a plan to hurt yourself after the session today? They may have answered yes. So again, just considering the exact meaning of what we're saying and being really thoughtful about our language. This is one of my favorite quotations. I did a qualitative study when I was in Philadelphia and had the opportunity to talk with autistic adults about their experiences with mental health clinicians. And this quotation really stuck out to me. So one of my favorite sayings is say what you mean and mean what you say, especially with working with people on the spectrum, because we're not going to get the nuances. So if you don't say it, I didn't hear it. All right, here is a newer, kind of hot off the press toolkit that Lisa and several others I'll highlight here in a moment and I have been working on. So this resource contains a proposed set of warning signs for autistic people based on research findings and expert consensus. And this was an international collaboration between the 6 people pictured here. Again, Lisa had this brilliant idea and brought this group together. And this group does span a wide range of experiences, many with multiple experiences and roles, including autistic people, researchers, practitioners, and those with lived experience of suicide loss and suicidality. So the purpose of this resource is to enhance discussions with autistic people. It's not a substitute for professional support or risk assessment. So we do want to make that clear. It's not a standardized risk assessment, but instead provide some guidance for individuals who may be, again, working with or supporting autistic individuals about how to talk about some of these warning signs and suicide risk. Our motivation for developing this is to improve the understanding about signs of imminent suicidal behavior in autistic people. And really, we want to prevent misunderstanding, and we want to prevent something that I've, again, learned a lot from Lisa about, unintentional harm. So many non-autistic individuals, non-autistic clinicians are causing unintentional harm. They don't mean to, but by misunderstanding or by communicating in an unclear way with autistic people, by not tailoring their practices to fit the learning styles and the unique needs of autistic people, we can be causing unintentional harm. And so we're hoping with this resource that we can decrease the instances of unintentional harm and misunderstanding, especially in this realm, right? Misunderstanding can have really devastating consequences. And I want to highlight here that devastating consequences can kind of go in different ways. I see it as kind of the both ends. If if I, as a clinician, miss a warning sign of suicide, right? If I'm working with someone and I miss a warning sign, that of course can have really devastating consequences. They could hurt themselves. They could kill themselves. Kind of worst case scenario. On the flip side, if I misunderstand and I think someone is at imminent risk of suicide when they're not, I might send them to the emergency department or pull in some kind of crisis supports. And that could also be traumatic and potentially lead to unintentional harm if it's not what the autistic individual needs in the moment. So a lot to think through about this. And I definitely love to hear people's thoughts about this in the discussion time. So again, I'm not going to go through this whole resource now, just give you a brief overview of the structure. We have the 10 warning signs, case examples or scenarios to highlight each of the warning signs, the emerging research findings, and then additional resources about autism and suicide prevention, ending with a one-page summary that clinicians can use in real time. So we don't expect people to be going through all of the pages of this resource, in session. All right, so I will very quickly just share these 10 warning signs and then encourage you to read more about them from the toolkit. I will provide a few examples as well. So the first is suicide, sudden or increased withdrawal. The second is no words to communicate acute distress, a current traumatic event, a marked increase in the rate and or severity of self-harm, a worsening of anxiety and or depression, a new focus on death-related topics that are not a special interest or not a restricted interest. That's an important qualifier. Perseverative suicidal thoughts and ruminations, seeking means or making plans for suicide or suicide rehearsal, statements about no reason for living or no sense of purpose in life, and a feeling of hopelessness. So the resource itself has some really, I think, beautifully written case examples to highlight each of these. Just to give you a couple of quick examples, the no words to communicate acute distress. This is one that's not listed, right? So hopefully one takeaway here is that some of these warning signs should look familiar if you're familiar with the warning signs of suicide in the general population. So some of these are very similar. And then some are different. And so no words to communicate acute distress. There's actually very little research on this, but we have heard from many autistic individuals, both in the development of this toolkit, and then in the few months since it came out, when Lisa and I and others have been presenting on this, we've been hearing from autistic individuals that they have this experience as well. And again, it highlights how autistic distress may look different than neurotypical distress. So no words to communicate acute distress can mean becoming very quiet, not really showing any outward expression of being upset or being distressed. So it's not crying, it's not showing that agitation, it's not talking about feeling distressed or upset. And I've seen this happen with some of my autistic collaborators in meetings where something is triggering, and I probably would not be able to tell unless they tell me that they are really experiencing high levels of distress, because all it looks to me from kind of the outside is almost calm, right? So just very quiet. And so we're spending a lot of time talking about ways that we can kind of anticipate this ahead of time and ways that we can still communicate in that moment, because we've heard from autistic individuals that this is a really scary experience when they want to ask for help. And they feel like they're at a loss of accessing words to communicate that. All right, probably could give a whole presentation on just that, but for the sake of time, I will move on here. I want to make sure we highlight some crisis supports and resources. I do have to give another disclaimer. Despite their increased risk, unfortunately, very little research has examined how to mitigate suicide risk in autistic people. This has really been overlooked. There is no research on, no published research at this point on the effectiveness of suicide interventions for autistic individuals. We're working to change that, which I'll talk a little bit about here in a minute. There are also no evidence-based or consensus clinical guidelines for intervention specific for this population. So what can we do, right? In the absence of published research in these large trials. I will share some resources and some toolkits that are out there. I also think that we can kind of step back and think about those risk factors that I presented near the beginning, and think about what are some strategies that we can put in place now that would have an effect on some of those risk factors. And when I think about that, I think about how effective strategies have to go beyond the autistic individual, right? So as a mental health clinician, I'm often thinking about kind of individual level interventions, right? Cognitive behavioral therapy, dialectical behavior therapy. But really, I think to make a larger positive impact here, we really need to think about strategies beyond the autistic individual, particularly thinking about the discrimination and stigma that many individuals are experiencing kind of at a societal level. So what can we do at a societal level or at a systems level or at an organizational level to decrease the risk of suicide? And I love this quotation from Lisa. Lisa and I often co-present together. So when I present without Lisa, she knows that I work her words in here as much as I can. So it feels like we're still presenting together. So Lisa said this during a symposium presentation at the International Society for Autism Research last year. Understanding autism and the culture of autistic people, so autistic people do not have to mask or camouflage their autism, is suicide prevention. And those words, I think, have such a powerful impact when we think about, what is suicide prevention? Suicide prevention is more than safety planning intervention or cognitive behavioral therapy or medication for depression, right? When we think about the masking and camouflaging and other risk factors and what we can do as a society to better understand the culture of autistic people, I think that's where we need to spend a lot more time figuring things out. So some of that is included here in the Crisis Supports Toolkit. So this is actually how I first learned about Lisa's work and also the Autism and Suicide Committee. I was working with autistic adolescents and adults, and I was hearing a lot about suicide, suicidal thoughts, suicidal behavior, and I had not really been trained much in what to do, how to best support autistic people, right? Because there are no published guidelines. So I went to, of course, trusted Google and was Googling autism, suicide, crisis supports, things like that. And this toolkit was one of the first things that popped up. So that was very exciting for me that someone else was also thinking about this and actually making progress with getting resources out there. So Lisa and the committee designed this toolkit specifically for crisis center workers. So if we think about people in crisis, right, they have the crisis center number that they can call. They can also text, crisis text line. The people on the other end of those calls and texts, not surprisingly, do not get training in autism. So how can we better support crisis center workers, support them to support the autistic callers and texters? So this toolkit both explains how to identify someone on the spectrum and then how to support individuals on the spectrum as well. I also like this resource from Autistica in the UK. They go through some different strategies about not only for suicidal crises, but also mental health difficulties in general, how to support autistic individuals and adapt services to make them more inclusive. So I like to highlight that as well. Hopefully it's been clear so far that I strongly believe to make progress in this area, we need to listen to different stakeholders with lived experience in this area and really learn directly from them. One group that has been doing this really well, as I mentioned, Autistica and also Dr. Sarah Cassidy, who's one of the lead researchers in this area of autism and suicide prevention. They got some support from the International Society for Autism Research to directly ask stakeholders to rank their top priorities for suicide prevention research. So they consulted with more than 1,000 autistic people and those who support them to identify and prioritize the top 10 issues they agree are most important. So they have this list of the top 10 priorities for suicide prevention research that I think is really interesting to think about and use it to inform what we're doing as researchers. I'm not going to go through all of these in detail. There is one that I want to highlight here. Number 6, how should interventions be adapted for autistic people? This was something that my wonderful collaborator and friend from University of Pennsylvania, Dr. Sherry Yeager-Hyman, and I have been thinking a lot about. There is an intervention called the safety planning intervention that is kind of frontline, evidence-based, brief suicide prevention intervention in the general population. So it has not been tested specifically for autistic people. And we wanted to see if it needs to be adapted for individuals on the spectrum. So we got some support from the FAR Fund, from a private foundation, to support this pilot study. I'll talk briefly about that now and then wrap up by talking about how this has led to our larger PCORI funded study. In case you're not familiar with the safety planning intervention, the safety plan is actually a term that's used a lot, I think, to mean different things. So I do just want to kind of ground us in what Sherry and I mean when we're talking about the safety plan. We're talking about the Stanley and Brown safety plan, which was developed by Dr. Stanley and Brown, shown here. Dr. Brown and Sherry and I all worked on the same floor at Penn. And so it was really this wonderful kind of marriage of Sherry's expertise in suicide prevention and safety planning intervention. She does a lot of work in the VA, so working with really high risk subgroups of veterans. But she did not know very much about autism. Then you have me. I knew more about autism, knew some about suicide prevention from my own clinical psychology training, but definitely not about doing suicide prevention trials or studying effectiveness of a safety planning intervention. So we brought kind of that complementary expertise together. And we really were interested to see if something like the safety plan, which can be individually tailored, might be a good fit with some modifications for people on the spectrum. So this is what the Stanley and Brown safety plan looks like in its kind of original version. This may be familiar to some of you here. It looks just like a worksheet, right? It kind of looks just like a form, but it's really not, if done well. It's a collaborative intervention where the clinician and the individual who's determined to be at risk for suicide go through and fill out these different steps together, ideally using the individual's own words, right? So going through each of these steps. And then the individual would have this safety plan that they bring home with them. And the idea is that they would use it on their own at home. So Sherry and I started this study with the idea that some aspects of safety planning are a really good fit for the learning style of many autistic people. It's written, it's concrete, and it's stepwise. About, I think, around a third or halfway through the study, COVID hit. So then there were a couple of other advantages of the safety planning intervention. You can implement it over telehealth, and it can help people manage suicide risk from home, like I mentioned, and people were spending a lot of time at home. However, our team did have some concerns about the fit of the unmodified or original safety plan for autistic people due to some of the kind of core differences that autistic individuals have related to social communication, interaction, emotion recognition and regulation, and executive functioning. But we weren't sure. We didn't want to make any assumptions ourselves. We really wanted to learn directly from stakeholders. So we conducted semi-structured interviews with autistic adolescents and adults who all had experience with suicidal ideation, their family members, and then clinicians. And we took what we learned from these stakeholders and we worked on adapting the safety planning intervention in collaboration with our community advisory board. So I'm not going to go through too many of these details today. I wanted to share that we did learn from stakeholders that there are many perceived advantages to the safety planning intervention for autistic individuals specifically. People like that it's proactive, it increases individual safety, it normalizes feelings and thoughts around suicide, it can be used as an educational tool. Both all stakeholder groups said that the structure is really helpful, not only for the autistic individual, but also for the clinician, kind of giving them a structured tool to follow. And that theme of it's individually tailored, it's so important, people told us, because again, no one person on the spectrum, no two people on the spectrum are exactly the same, of course. So being able to tailor the intervention accordingly was perceived as very advantageous. As we expected, we also heard about some difficulties or challenges with the unmodified version. People had concerns that it would be difficult to generalize, that it may be triggering, particularly the steps that are so focused on the social connections. There are multiple steps in the unmodified version of the safety plan that focus on social connections or social supports. And we heard stories about how upsetting that actually was to autistic people when they were already in distress to be asked multiple times about people that they trust or people whom they could reach out to. If they didn't feel like they had, 3 people to list in those spots, it was quite upsetting. We also heard some concerns about perseveration, concerns that some steps that involve introspection may be difficult, and that the plan may be overwhelming, challenging, and time-consuming. So just to give you a quick flavor of some of the modifications, we have maintained the kind of core ingredients of the safety planning intervention. What's interesting is that many of these suggested modifications map on really nicely to the published evidence-based modifications to cognitive behavioral therapy for autistic people. And that's nice to see because the safety planning intervention is a cognitive behavioral intervention. And so it's nice to kind of see that consensus. We've made the text a lot more concise. That one pager I showed you earlier, right? There are a lot of words on that page, and that was not a good fit for many autistic people. Trying to make the text a lot more direct, clear, reduce the word count. People said that it would be really hard to kind of fill in some of those examples, particularly around warning signs, and even the coping strategies without some concrete examples. So we have some concrete examples now that clinicians can use as kind of a supporting document. This sounds really simple, but I actually think it makes a big difference. Removing the lines and the numbers under those different categories. Having numbers 1, 2, 3 for people you can call gives this expectation that you need to have 3 friends or 3 close family members you can call, and that's not always the case. Having lines also suggests that you need to write down the words instead of perhaps drawing pictures. Some people may want to have pictures on their safety plan and not written words. So really just trying to increase the flexibility of how people can complete this. Again, decreasing the emphasis on social supports and settings. We got really good feedback that it doesn't always have to be a human that provides that support or provides that distraction. It could be a pet. It could be a favorite object. We also heard from many of our stakeholders that we need to have reasons for living front and center on the safety plan, that this is what has helped them in the past when they were in crisis, was to reflect on their reasons for living. And then incorporating more visual supports, which is visual supports. That's an evidence-based strategy and fits really well with many autistic individuals' learning style. All right, so to wrap up here in our last 5 minutes before the Q&A period, I just wanted to share kind of what has happened since Sherry and I were working on that in Philly, pictured here on the left, beautiful city of Philadelphia, which I do miss a lot. I know Dr. Powell also spent some time in Philly, so this picture probably brings back some memories for him as well. And then in 2020, during the pandemic, my family and I moved here to Chapel Hill. So my 2 kids now pictured here, they were city kids, born and raised in Philadelphia as city kids, and now they are totally country kids here in North Carolina, loving all our time on local farms. So moved here in 2020, and I will be honest, I was not planning on submitting a large-scale proposal in the first couple months of being a faculty member, but this PCORI funding announcement came out right after I started here at UNC, and Sherry and I got on the phone and said, oh my gosh, this sounds like it was maybe written for us. I think we have to do this. So this PCORI funding announcement was very much focused on the comparative effectiveness of different either evidence-based and or widely used brief interventions to reduce suicidality and improve outcomes For youth, PCORI defined this age range of 15 to 24 as youth. And here's the part that really got us. They said that they were particularly interested in culturally adapted approaches for underserved subpopulations with increased rates of suicidality. And they listed different subgroups. And we were just honestly thrilled with so much work that's being done to increase the awareness of suicide risk in people on the spectrum, that they specifically listed individuals with disabilities. And so we are so excited that we now have the opportunity to be working on this 5-year study that was funded by PCORI and officially launched January 1st of this year. Our long-term objective is to, of course, reduce the number of autistic lives lost to suicide by providing key stakeholders with the most effective suicide prevention practices for autistic youth. Because PCORI asked for a comparative effectiveness study, which basically means comparing two active interventions, we are comparing the safety planning intervention tailored for autistic individuals with and without a structured follow-up component. And I'm happy to talk more about that if people are interested. But our primary aim here is to look at the effectiveness. Do either of these interventions have a positive impact on reducing suicidal thoughts and behaviors, as well as some secondary patient-centered mental health outcomes. We're also looking at the implementation outcomes of acceptability and feasibility of the two interventions, as reported by different stakeholders, using both quantitative and qualitative methods. And then we have to think again, going back to everyone's insightful answers in the chat at the very beginning today, this enormous heterogeneity associated with autism. We're really interested in not only, which treatments work best, but for whom and under what conditions. So looking at those patient characteristics that may affect which intervention is the best fit. We're really fortunate to partner with 4 different health systems for this multi-site trial. So those are listed on the right side of the screen. And we're really embedding the research study into routine clinical care. So the modified safety planning intervention is delivered as standard care. And then for the patients who consent to the research study, we'll be following up with them to monitor outcomes. The clinicians are randomly assigned to implement one of the 2 interventions with all appropriate patients. And then the final point I want to highlight about this study is the community-based participatory research design. And this is really the other reason that I was convinced that I needed to spend all the time learning how to write a PCORI proposal as I was getting settled here at UNC. It's really because of these 2 amazing people pictured here, Dr. Stephen Shore and Dr. Teal Benavides. Stephen and Teal got a PCORI Engagement Award back in 2017 to develop a stakeholder engagement group called ASSET, Autistic Adults and Other Stakeholders Engaged Together. And they worked together with a group of about 18 autistic adults and also caregivers of autistic adults to work on setting priorities and identifying methods to support authentic autistic engagement in research focused on improving health and mental health outcomes. And so Teal and Stephen actually approached me when they saw this funding announcement too and said, do you want to do this together? And that was such an amazing ask, such an amazing opportunity. And so it's been really wonderful to work with ASSET from the very beginning on this, from working on the letter of intent to then working on the full application and now to executing this project, this very large project together. So ASSET helped us revise the research questions, identify priority outcomes for the study. We created opportunities for authentic autistic involvement in study roles, ensuring the methods were congruent with their priorities. And to do that, we had regular Zoom meetings over many months. We also voted, ASSET members voted through online surveys on choices related to study design. And if even one person said they did not feel comfortable with a certain approach, we did not proceed. Lots of email correspondence, and we asked ASSET to also help us brainstorm different organizational partners and other members to invite to be part of the project. So this is my last slide to show you all. It's a lot of words. I just want to highlight what a large team this is. It's such an honor to get to work with all these people. as part of our, we call it Asset SP, so Asset Suicide Prevention Study. And you can see this large stakeholder engagement core here in the middle of the screen. We have Asset Community Council here, as well as a multi-stakeholder advisory board who's advising us on the study. And anywhere you see a blue superscript A, this signifies an autistic individual or a family member of an autistic individual. So yes, we have our community council, more kind of an advisory role, which is really important. We also have autistic individuals co-leading the clinician training team, co-developing and co-delivering the clinician training. One piece of feedback we received from Asset was every interview with an autistic participant should be co-led by an autistic interviewer, which was such a great idea. Sherry and I were like, of course, we did not think of that. So now we have our implementation outcome evaluation team is co-led by our two autistic partners. We also have a study staff training team that is co-led by an autistic partner. So I could talk a long time about this team, but I'm going to stop myself for the sake of time. I really want to make sure we can get to some questions. Thank you all for listening, and again, for the opportunity to present today. I really appreciate it.
Thank you so much, Brenna. That was incredible. And we do have a couple questions from the chat. And so I'll start there, but folks, if we have time, feel free to add more. The first from Carolyn, and I'll just add this, I'll just read this if I can. She says, thank you for your presentation. One of the questions I have is regarding adapting SPI. Did you encounter issues when working with community advisory board to adapt such as disagreement between the research team and board about what to change? And how did you negotiate these issues to reach a consensus?
That's such a great question. I would say where we had to make some more decisions about that was probably in the interpretation of the interview data, right? So we conducted these qualitative interviews, and we worked with our team, including an autistic collaborator, to extract those key themes. So, not everyone we interviewed said the exact same thing, but we worked as a team to extract the key themes and then presented those to our community advisors to make sure that they felt good, felt right. And then when we got time to actually making the changes to the safety planning intervention, it was very iterative. That's probably the best description for it, where we'd make the changes, feel like we kind of got it, and then come back, present it, and we still didn't get it quite right. So then we would take the next round of feedback, make some more changes. Then we also got to a point where our graphic design skills had reached their limit. So we had to pull in a graphic designer. And actually, we're still working on that last part of what's the best kind of design. We got the content there, but in terms of kind of the design piece, that's still an iterative process right now. So I think for that, probably in hindsight, there are ways that we could have improved some of the kind of consensus determination or decision making. We have given a lot more thought to that for our current PCORI study for decision making. So I'm happy to talk more about that offline if people are interested. We have a whole decision making structure in voting that people participate in now.
Great, thank you so much. And next question is from Rob Fitzgerald, who asked, the warning signs of suicidality for autistic individuals you mentioned seem to me to apply to the general population. Did you see them as being unique in some way for autistic individuals, or is it more about the presentation of these warnings, signs, or risk factors?
Yeah, that's a great question. I think it's both. So I think some are the exact same wording as the warning signs for the general population. And I do see a lot of overlap, both clinically and in the limited research that we have out there. And then I think a few others are more unique. I think the main one, which I highlighted today, is the no words to communicate distress. That's not out there for the general population in terms of a warning sign. It might be for some individuals, but I think when clinicians particularly are thinking about their non-autistic clients and how they kind of present in crisis, it's typically, it does typically look really different in that regards in terms of that kind of loss of words to communicate. So I think that's a big one. But I think the second part of what you said is also really true, and is what that first toolkit was about. So what are some kind of considerations about how this may look? So for example, the sudden or increased withdrawal, we really make clear that some social withdrawal oftentimes is a healthy coping strategy for autistic people. So we wouldn't want someone to think, oh, this person's withdrawing after school or after work. That's a warning sign for sure. So really focusing on that, increased or sudden withdrawal to signify that this might be something to get some more information about. So those kind of considerations are highlighted as well.
Great. And feel free to ask follow-up questions or additional questions in the chat as we have a few more minutes. Brenna, I have a sort of a broad question that is, one, I'm amazed by the community engagement and sort of the broad engagement in your work. And for those on the call that aren't in an academic environment, believe it or not, sometimes like early career academics are encouraged not to do this kind of work because it takes so much time and effort.
Yeah.
And it's a real challenge, but it's obviously important to you, and it's great to see that value. I wonder if you have any sort of broad lessons learned, either like I did this terribly or I would do this differently, or things that you think you've done really well or you've learned through the process that you could share.
Yeah, absolutely. I mean, this is going to sound probably so obvious, but just the amount of time that it takes to do this well, and not to feel rushed. So I've been learning a lot from Stephen and Teal, the co-leads of Asset and the co-leads of our stakeholder engagement core about this. So I just give you a really concrete example. So we have a lot of meetings with Asset to make study decisions and to discuss things. And preparing for those meetings does take a lot of time. We want to make sure that we're accommodating different communication preferences and things like that. And then one thing that Teal and Stephen brought up was we want to make sure in those 1 hour meetings, we as kind of the team leaders aren't talking the whole time. We actually really want to spend most of that time together on Zoom, hearing from everyone else. So we've started pre-recording kind of more of the didactic or, information heavy slides. We'll make videos of that part ahead of time, send out those videos a week or so in advance so that people can watch those videos ahead of time and then come to the meeting and really let them talk. So I would say that was probably a lesson learned of where early on I was doing a lot of talking in those meetings, and that's not the way it should be. I'm there to learn from my autistic collaborators. Takes more time to make those videos, prepare that content in advance. I can't be working on it the night before. But it really has led to just amazing learning opportunities for me in these meetings to really sit back and learn from the people with direct lived experience around this.
Great. And I know we're right up against time here. So I might just say thank you so much, Dr. Maddox, for your presentation. That was really tremendous. And for all of you who attended, if you have colleagues or friends or collaborators that might be interested, this will be posted through the Open Classroom platform, as well as through our Center for Mental Health Services research website. Thanks so much for attending. And Dr. Cabasa put the link for our next CMHSR seminar in the chat here. So hopefully you can grab that and register if you're interested in that. Thank you all for attending, and hope you all have a great rest of your day and week, and we'll see you next time. Thank you again, Dr. Maddox, for your presentation.
Thank you again for having me.